Hello, Dr. D here. Globally, we are faced with the problem of antimicrobial resistant organisms and untreatable infections. Although antimicrobial resistance is a normal evolutionary process, the rate of resistance development has been accelerated by the inappropriate use of antimicrobials. Most pathogens have developed some degree of resistance to all available antimicrobials, and the development of new novel agents has been scarce, limiting alternative treatment options. Pharmacists, as a custodian of medicine, should continuously and persistently advocate the responsible use of antimicrobials. A large systemic analysis published in Lancet in 2022 estimated that 1.27 million deaths were directly attributable to resistance in 2019. An overall total of 4.95 million deaths were associated with bacterial AMR globally in 2019. Lower respiratory tract, bloodstream, and intra-abdominal infections were the three infectious syndromes dominating the global burdens attributable to and associated with AMR in 2019. The pathogens associated with AMR can be seen on the right-hand graph. View the article online for more detail regarding this. Do you know what an antimicrobial agent refers to? Many think it only applies to antibiotics, but in fact, an antimicrobial agent also includes antifungal, antiviral, and antiparasitic agents. So antimicrobial resistance refers to any one of these four groups. Antimicrobial resistance occurs when changes in bacteria, viruses, funguses, and parasites cause the agents used to treat infections to become less effective. It is one of the leading public health threats of the 21st century. This led to countries across the globe to implement antimicrobial resistance strategies to combat resistance by improving the utilization of existing antimicrobials. Antimicrobial stewardship refers to the set of actions to promote the responsible use of antimicrobials. Antimicrobial stewardship programs incorporate these set of actions in healthcare settings, and it should reflect in a facility's strategic plan. Guidelines were developed to assist healthcare facilities in implementing antimicrobial stewardship programs. A team responsible for an antimicrobial stewardship program should be constituted as a multidisciplinary team, including but not limited to infectious diseases specialist or a senior physician with infectious diseases background, representatives of the Pharmacy and Therapeutics Committee, representatives of Infection Prevention and Control Committee, clinical and or the ward pharmacist, clinical microbiologist, representative of healthcare facilities management, and last but not least, representatives of IT and quality control. To optimize antimicrobial prescribing is one of the key requirements and functions of an antimicrobial stewardship program. Together with the IPC team, it contributes towards reducing healthcare-associated infections. Management should understand the requirements and functions of such program and provide the necessary support. Leadership should be accountable and furthermore ensure all healthcare professionals are exposed to continuing education programs. This will promote adherence to good antimicrobial prescribing. Other important functions include to survey data sets of antimicrobial consumption and resistance patterns. This has to be followed up by feedback of surveillance data to key stakeholders. The adherence of guidelines should also be assessed. An antimicrobial stewardship program should have flexibility to respond acutely to emerging challenges, as all of us have learned from the COVID-19 outbreak. We should all be responsible antimicrobial stewards. For instance, the doctor should make an accurate diagnosis and follow the local prescribing guidelines and regularly review the need for an antimicrobial. In hospitalized patients, it is also necessary to switch from IV to oral therapy when appropriate. A pharmacist should liaise with doctors to rule out any discrepancies, for instance, drug-drug, drug-food, or drug-patient interactions, and also liaise with members of the multidisciplinary team to ensure appropriate patient management. Pharmacists should handle all queries or issues timeously. Remember to always work within your scope of practice. For instance, do not dispense an antimicrobial over the counter. Microbiology should improve data collection systems, and the microbiologist should provide timeous culture results. They should also supply an antibiogram for hospitals or clinics and expand microbiology laboratory capacity. Nurses should take cultures correctly and do not skip any doses. It's important that they administer timeously according to the prescription, and here we think of time versus concentration dependent agents. And they must make sure a patient understands how to take antimicrobials upon discharge. The AMS team should create or follow guidelines for antimicrobial use, support audit and feedback to the team, and educate fellow healthcare professionals. Hospital governance should ensure sufficient, sustainable, and dedicated funding for AMS teams, monitor antimicrobial use and AMR, invest in a clinical decision support system, and enable formulary restrictions. National policymakers should prioritize and fund AMS activities and support the use of quality metrics and pay for performance. Pharmaceutical companies, they should limit the advertising of antimicrobials, especially broad spectrum, and ensure a continuous supply of antimicrobials. When it comes to the producer or the farmer, they should refrain from using antibiotics as growth promoters. Even the patient should be an antimicrobial steward, because they should not demand or expect an antimicrobial when not necessary, and they should use antimicrobials exactly as directed and never share antimicrobials with friends or family. Do not store or use leftover antimicrobials. Antimicrobial prescriptions should be safe, rational, and effective with minimized unintended consequences. The key to AMS is to reduce the inappropriate use of antimicrobials. This can be achieved by preventing or delaying the initiation of antimicrobials, to reduce the duration of treatment, and to reduce unnecessary broad-spectrum treatment. Use evidence-based guidelines to standardize practice, and remember about the intravenous to oral switch programs. But more on this on the next slide. When is it appropriate to switch from IV to oral therapy? Criteria include clinical improvement has been observed and that there is no condition-specific contraindication to oral therapy. Oral fluids are also well tolerated, and the patient's temperature has been within normal limits for at least 24 hours. Exceptions do exist For instance, exclusions to this IV to oral switch applies to patients with compromised oral absorption, continuing decompensated sepsis, and endocarditis. Relative contraindications to switch or indications for a delayed switch include patients with meningitis or a brain abscess, osteomyelitis, complex skin and soft tissue infections, deep abscess, and bloodstream infections. Audit and feedback are two important aspects when it comes to managing antimicrobials. A pharmacist can do a post-prescription review and compare the indication, use, and duration of treatment against accepted guidelines. But then it's also important to provide feedback, and feedback should be given by a superior and preferably both verbally and in written format. And this feedback should be provided to the entire AMS team and hospital management. In this feedback report, it is important to include the appropriateness of the decision to initiate antimicrobial therapy, appropriateness of the choice of agent and adherence to the local guidelines, appropriate specimen taken for culture and sensitivity tests before initiation of empiric antimicrobial therapy, report back on the discontinuation of antibiotics, the intravenous to oral switch, de-escalation from broad spectrum to narrow spectrum agents, and dose optimization. Furthermore, report back on drug therapy monitoring or TDM, for instance for antibiotics like aminoglycosides, the time lapsed from prescribing an antimicrobial to actual administration, or also referred to as hang time. Report back on penicillin allergies, whether it was confirmed or not, and then any missed doses or incorrect administration times. Another important aspect in managing antimicrobials is monitoring. To assess the effects of an antimicrobial stewardship program, it is important to monitor antimicrobial usage or consumption, processes, and the outcomes. A common way of monitoring consumption is the defined daily dose or DDD. And this is the assumed average maintenance dose per day for a drug used for its main indication in adults. The DDDs are allocated to drugs by the WHO Collaborating Center. It is a unit of measurement and does not necessarily correspond to the recommended or prescribed daily dose, and provides a rough estimate of consumption. The defined daily dose provides a fixed unit of measurement independent of price, currencies, package size, and strength. Pharmacokinetics and pharmacodynamics need to be taken into consideration when managing antimicrobials. Antimicrobial stewardship programs promote the selection of optimal antimicrobial regimens. This includes checking for the right dose at the right times and the right dosing intervals for the right duration of therapy and the right route of administration. Therefore, in your feedback report, you have to include therapeutic drug monitoring, as certain antibiotics need or require TDM to ensure the patient receives the right dose at the right times. It is important to consider and implement antimicrobial regimens based on pharmacodynamic concepts. And that is it. I hope you have gained some insight into antimicrobial stewardship. And I can ask you, are you an antimicrobial steward? If you've enjoyed this video, please give me a thumbs up and subscribe to my channel. All the resources I've used can be found in the description below. Thank you and bye-bye.